And in the place of Michael Lichtenberg, Professor Sayers is going to talk to us about the implications of Best CLI.
So thank you very much, chairs, ladies and gentlemen. I've been asked to talk about this trial that you may be familiar with and comment on its implications for modern practice. I'm going to break this tradition and put my disclosures up for more than a millisecond, and so you can read them. The important thing is that I get paid by NHS England to advise them and help them how to commission vascular services in England. So this trial, Best CLI, published last year in the New England Journal of Medicine, which is important. Before we rubbish these trials, which I suspect that's what the sport's going to be today, to get your trial published in the Lancet or the New England Journal is a phenomenal achievement, and not many people do achieve that. This trial was American-led on the treatment of CLI, or what perhaps we would know as CLTI, 150 sites, mainly the USA and Canada, and one or two other countries. I'll cut to the chase and give you the final answer. So essentially, it was called Best CLI because it compared the best surgical option with the best endovascular option. And the bottom line is, if you had good long saphenous vein, it was said that bypass was the best option for you. If you needed an alternative source of vein, that could be arm vein or arm and leg vein joined together, splice vein or prosthetic, the results were not as good, and you could do whatever you like because there was no difference. And then on the issue of whether it will change UK practice, I think the answer to that, and I'll explain why, is probably not. So if you look at that in a bit more detail, it dealt with infrainguinal disease. It had two cohorts, which I'll describe to you. They were independently powered and independently analysed, and there was further stratification in terms of severity of disease, that's rest pain against tissue loss, and the presence or absence of tibial artery disease. The first cohort was where on duplex scanning you had a good long saphenous vein, cohort 1, and cohort 2 was the so-called alternative source of vein, so poor long saphenous vein or the use of arm vein, splice vein or prosthetic. It had an unusual primary outcome. In addition to death and limb loss, which is a composite endpoint, which perhaps we would know as amputation-free survival, it also included what they called major adverse limb events, which included re-intervention. We could argue whether or not re-intervention is seen as a good or a bad thing by us and by the patients, but that was in their primary outcome. And for the endovascular doyens in the room, the trial was keen to point out that it was a modern trial of endovascular therapy, and again, some of you might dispute that. This is what I've just said in pictorial form. The two cohorts, depending on vein quality, further stratification. The key thing here is that you had to be fit for surgery, not at excessive risk for surgery, and that certainly doesn't reflect the sort of patients that I see with CLTI. In terms of the outcomes, I've dealt with the primary outcome where re-intervention was part of the primary outcome. The two cohorts are showed there. As you expect, cohort 1 was the bigger cohort with a 2.5-year follow-up. Cohort 2, the smaller cohort with a 1.5-year follow-up. And these are the results for cohort 1. So the top left shows this composite outcome of major adverse limb events, including amputation and death. And the three other graphs are re-intervention, death, and above major amputation, which contribute to that primary outcome. And you can see the two groups of endovascular or surgical therapy with the shaded areas representing the confidence intervals. And so the results for cohort 1 showed this hazard ratio of 0.68. So they were able to say that bypass was associated with a 32% reduction in this composite primary outcome. And that result was driven by the highlight in blue. In the surgical arm, there were a reduced number of major amputations, and in the endovascular arm, more re-interventions, as I've described. Cohort 2, the results were not as good, but no difference between the two treatment arms. Lots of limitations to the study. I've mentioned some already. Again, we shouldn't trash these studies because they are very, very important. But these things might cause you to think again and raise your eyebrows. So should re-intervention be in the primary outcome? That's an issue for us. There were no patient-reported outcomes, so they didn't ask the patients what was important to them. We've not seen a health economic analysis yet, although I understand there's one coming. Quality of life was reported and there was no differences. The trial was stopped because of funding issues, and then they sought extra funding, which they obtained, and therefore continued the trial with the follow-up. There were lots of centres and the recruitment was relatively poor. They recruited in total 1,800 patients across 150 centres, so over 6 years. So each centre had to recruit perhaps 2 or 3 patients a year. And again, I don't think that represents the practices that we all see. There is an issue as to whether the endovascular interventions were modern or out of date. And again, it was deemed that you had to be fit for surgery, which again doesn't represent the sort of cohorts of patients that I see. The funding was eye-watering. Andrew will tell you about the Basel funding, but I think it was about £2.5 million. This trial, the funding for this was $27 million to run this trial, and they ran out of money. They then went to industry, and you can see the top-up industry input there and the various regional societies across America and Canada to get extra funding to finish the trial. The other issue is that there is lots of supplementary data, 61 pages of it, so that's 6 times the length of the primary publication. The problem is that you can't really get an overall understanding of this trial unless you read the supplementary data and you lose the will to live as you try and wade through all this. It's of this format. But you can see here that in terms of the procedures often offered, FemPop bypass was about 40%, distal bypass 30-35%, and the rest were pop pedals. Very similar to Andrew's trial on Basel 1 all those years ago. They also lumped in lots of things together, so they didn't separate out the various anatomical issues, and it was not clear to me whether all centres had equivalent expertise. So where does this trial and perhaps Basel that you're going to hear about sit? I think there's no doubt that they raise awareness of PAD, and it sits in this sort of field where we've heard today about the PADQUIF targets, which have been helpful. We know that delays to treatment in terms of delays to revascularization is very important, and we've heard about NHS England's scheme to incentivise centres to revascularize early, the sequence scheme, and we're all familiar with hot leg clinics that many of us are trying to set up to treat patients quicker. So that's all a good thing. Does it change practice? Well, I don't think so. I think this is what most of us do. I think we have to stop thinking of surgery and endovascular as adversarial issues, and they're probably complementary. One size does not fit all. It's important to talk to patients and see what they want, and one of the pillars of the NHS is now shared decision making. Again, I think we look at fitness for surgery, we look at frailty and comorbidities, etc., and then we look at the lesion in terms of quality of vein, runoff, inflow, length of the lesion, calcification, etc., etc. So I think that's what we all do, and I don't think that this trial emphasises that enough. The other issue that we all have in the sort of the post-COVID era is I think we all find difficulties in terms of resources, so getting into wherever you need to be, that may be an operating list or a hybrid theatre or an angio room or whatever. I think that's very difficult if we're going to run a new policy of everybody having bypasses. Thank my colleague, Professor Thanos Saratsis, for this slide. I think it's very important. So if you're a doctor dealing with coronary disease or cerebrovascular disease, you have lots of trials which can inform your practice for patient benefit. We only have Basel and this trial, so these trials are very, very important. And they'll be debated for years. Andrew will tell you about data sharing agreements and whether there's going to be sort of meta-analyses of the trials, but we'll be talking about them for years, and they are very important because they are all we've got at the moment. So in conclusion, it's hard to know what to make of all that, but I think you see this trial as raising awareness of PAD along with lots of other things, so that's a very good thing. It stimulates debate, that's why we're all here talking about it, but in my view, it doesn't change UK practice. Thanks very much for listening.
Now Professor Bradbury is going to speak to us about Basel II. Thank you.
Thank you very much. It's a great pleasure to be here, and thank you to BSET and the organisers for giving me this opportunity. So I have no disclosures. On the 25th of April, the Basel II trial was presented for the first time at Charing Cross, and I suspect many of you may have been there. Lots of familiar faces in the room. And it was published the same day in The Lancet. And I'm going to make an assumption, which I hope is not a false assumption, that most of you will have seen these data and will have read the paper. So I'm just going to go very, very quickly through the headline data, and then I'm going to sort of ask myself, if you like, a few questions, the sort of questions I would ask if I was kind of reading this work. So this is the headline: amputation-free survival, intention to treat analysis. And what it shows is that patients who were randomized to IP vein bypass, as opposed to IP BET first, were around 1/3 more likely to require a major amputation, above ankle amputation, and or die from any cause over a follow-up of median follow-up of 40 months. And you can see the hazard ratios and the confidence intervals below. No evidence of non-proportional hazards. And I'll come back to statistics a little bit more later. If we look at time to first major amputation, we can see that BET is somewhat better than VB in the short term, but out to 5 years, the limb salvage rate, if you like, is around 75 to 80% in both groups. But by then, the numbers at risk are very low because, sadly, over half of the patients have already deceased, and there was no difference in the level of major amputation. So actually, the difference in amputation-free survival that we observed was largely due to excess deaths with vein bypass. And again, you can see the hazard ratios and the confidence intervals here. And again, no difference in non-proportional hazards. So if you look at the 50% survival rate, you can see that the patients having BET got about an extra year of life compared with those that were randomized to VB first strategy. So, any questions? Is preventing death in CLTI patients now actually a greater challenge than preventing amputation? Well, the Basel II whole cohort median survival was around 5 years. That's actually very similar to Basel I, which was done, started in the last millennium. Limb salvage, pretty good. You could say 75 to 80% in both groups. Given the patients that we have to deal with these days, that sounds, quite optimistic. But again, to remind you that over half of the patients were dead by 5 years. So it's clear that there's a lot more to the optimum, the best treatment for CLTI than, if you like, fixing the plumbing. And what happens before the intervention, and even perhaps more so what happens after the intervention, was seen to be equally important to getting optimum outcomes. So what can we do as vascular surgeons and interventional radiologists to improve outcomes, and particularly this terrible mortality rate? And we've heard that nice talk earlier this morning about attempts to improve the overall care of this patient group in this country. At presentation these days, is it too often, too little, too late? 90% of the patients in Basel had tissue loss, often quite advanced at presentation. Around a third had or shortly developed bilateral CLTI. Many of the patients were deemed unsuitable for revascularization. At least a quarter of the patients are still smoking. 2/3 have diabetes, mostly type 2. Half of them are insulin. But the data we have show that the diabetic control and lipid-lowering therapy was often poor, often very poor indeed. So it's hard not to escape the conclusion that there are multiple missed opportunities in primary care and public health in terms of lifestyle interventions, best medical therapy, earlier diagnosis and specialist referral, and yes, perhaps earlier intervention. And those of you that do medical legal work will know there is a tsunami of claims now, largely directed against colleagues in primary care for failing to refer patients in a timely manner, and in particular, not following NICE diabetic foot guidelines. So are the Basel II outcomes probably real and a fair reflection of what can realistically be achieved in our very challenged National Health Service? Well, just picking up on a couple of points that Rob made, Basel II is funded entirely by NIHR. There is no industry involvement or funding at all. The funding was actually only 2 million, and we haven't spent it all yet. Still a few pennies left. Best CLI actually was greater than £25 million, and they've got roughly another £10 million from industry. Massive funding. I'm trying to hide my envy and jealousy, but not really managing very well. So the NIHR RCT program aims to identify the most clinically and, yes, cost-effective treatment on the NHS. And of course, this gets picked up by NICE. Around 80% of UK vascular units contributed. More than that actually registered for the trial, but some were unable to unable to recruit any patients at all. So I think it's a pretty good national effort. Highly pragmatic trial. Very, very few patient exclusion criteria, and Rob's pointed out that there were quite a lot of exclusion criteria in Best CLI. And unlike Best CLI, we felt it was inappropriate to undertake what they would call credentialing of centres and vascular surgeons. Because at the end of the day, this trial has to reflect real-world UK practice, warts and all, for all the shortcomings that we know exist there in the health service. Because if it doesn't do that, it's not useful, certainly not useful to inform practice and policy going forward. Are the results only applicable to a subgroup of patients? Well, yes, and the generalizability issue, which again is another issue that Rob has touched on, this only applies to patients who are offered an infrapopliteal with or without a FEMPOP revascularization. And in our Basel prospective cohort study, which I don't have time this morning really to present to you, that's about 20% of all of the patients that come through the door with CLTI. But in addition, the patients had to fulfill triple equipoise. So the MDT had to have intellectual equipoise, if you like, that neither vein bypass or BET were obviously preferred. But importantly, they had to have logistical, if you like, operational equipoise, that they believed that they could deliver VB and BET equally well and in an equally timely manner. And it became apparent, speaking to colleagues up and down the country, that that's often not the case, that it was easier, I use the word easy sort of in inverted commas, but it was easier to offer BET than it was vein bypass for various logistical reasons. And of course, most importantly of all, the patients have to be happy to be randomized. And as you can imagine, in this patient group, there's quite a big push to avoid surgery, all things being equal. So this triple equipoise is very important, and it's likely to vary between centres. And I visited every centre, many of them twice, and I observed very, very big differences in practice between different centres, sometimes only literally a few miles apart. But it's going to vary even more between different countries and different healthcare systems. So it's very difficult to compare Best CLI in a US patient group in a patient healthcare system with with our reality, if you like, here in the UK. Is the finding in favour of BET convincing? So this is the hazard ratio 1.35. These are the confidence intervals and the p-value. And if we were to rerun Basel 2 over and over again for eternity, and as the CI who spent the last 10 years of my life doing this, that would seem like an exceptionally cruel Promethean punishment. And if we keep on sampling from the same patient group, it's very unlikely, less than 2%, that we would find VB to be associated with better amputation-free survival. The most likely thing is that we would conclude that an IP-VB first revascularization strategy is associated with around a 1/3 increase in no amputation-free survival. So that's a 1/3 increase in major amputation and or death. And it's least likely that we would conclude that BET is associated with either a 2 or an 80% increase in no amputation-free survival. Now, if you look at the spread of confidence intervals running those trials over and over again, I think most of us would conclude that most of those findings in favour of IP-VET equal a clinically important difference for the patient, and we might debate that. So what about the all-important cost-effectiveness? Well, we know from Basel 2, from Basel 1, from lots of other studies, that VB does consume greater resources than endovascular treatment. It is more costly, quite a lot more costly. HRQL, it's somewhat better in Basel in the BET group, but the differences are not huge, and you may argue not of clinical, it may be statistically better, but maybe they're not meaningfully better. So I'm just going to share with you a little bit of the cost effectiveness. Now, this is not finalised data. It's still being written up. We've got a paper in preparation for circulation. But I'll just share with you a couple of slides, if I may, which I think you might find interesting. So this is the Basel II cost effectiveness plane for years alive without amputation. So that's amputation-free survival out to 7 years. So this is the whole of follow-up, basically. And I don't know how familiar you are with these kind of planes, but what it shows is that BET dominates vein bypass. It's cheaper and the outcomes are better. So it's cheaper and you get more years alive without amputation with BET first. If you look at the cost utility plane, and this is where we look at quality adjusted life years, and this is out to 3 years because the number of patients at risk and the data beyond 3 years becomes a bit wobbly. But again, you can see that BET dominates vein bypass in terms of quality of life. So what does that mean if we look at cost effectiveness acceptability curve? And the willingness to pay threshold in the UK is around about £20,000 to £30,000, with some exceptions for particular conditions. And what the SEAC shows is that BET is highly cost effective against a very wide range of willingness to pay thresholds, and certainly well within the willingness to pay threshold boundaries that we tend to work with here in the UK. So that's it. And I suppose the question is, will it change practice in the UK? I expect Rob's going to say no. But if so, to what extent would it make you alter your practice with the patients that fall into the sort of patients that were randomized in Basel II? So thank you again for the opportunity for speaking, and very happy to take questions in the discussion if there's time. Thank you very much.